Our sponsor today is Simplify OR. Simplify OR is the brainchild of Jim Furch. Jim has spent 13 years working in the supply chain side of healthcare, and with this experience, he saw a lot of snafus in the billing system, particularly for implant surgeries. It's an intensive paper process. Usually from the OR, the paper trail moves through 23 departments. There's all this manual workflow. Everybody gets a look at the paper, to make sure the case is billed to the patient correctly, that it's charted to the patient, that they've, updated the materials management system, and that it produces the purchase order at the current contract pricing. So it's really time and management and manpower consuming. So Jim created a software program to automate implant case management. And the first group to use it is a group in Tupelo, Mississippi, practice named Specialty Orthopaedic Group. Now, in the last approximately year and a half, they have processed over $14 million in implant cases. And during that time, they have found as much as a 95% reduction in manual workflows. That includes up to an 85% reduction in implant sheet processing, an 85% reduction in purchase order reconciliations, and a 95% reduction in case remediation. So using this software program, they have managed to save this particular practice over 16,000 manual hours. So this is well worth it for any hospital or surgery center that is doing implant cases. So again, we want to thank Jim and Simplify OR for sponsoring us today. All right, we're back with Dr. Davis, Dr. Jeffrey Davis from Andrews Sports Medicine. If you didn't see, last week we had Dr. Davis talking with us. He actually had gone through his own experience with COVID. But what we want to talk about now is he's also really experienced with joint replacement. So we're going to talk about that and some of the other aspects of his practice today. So to start with, Dr. Davis, I understand you were one of the first surgeons in Birmingham to use Stryker's Mako smart robotic technology. And can you explain what that is?
So smart robotic it's called the Mako system. It's It was founded. It was out of Florida. It's a robotic system that primarily was used for unicompartmental arthroplasties, or single parts of the joint, for many years. And then Stryker bought the system and then developed use for total knee arthroplasties and for total hip arthroplasties. Okay. They're expanding it soon, I think, to total shoulders too. But right now it's total hips, total knees, and then partial knees. And so the idea is that you can get a CT scan of the body part, the knee or the hip, and then plan the surgery with the implants. So you have some idea of what it's going to do or how it's going to sit, and the sizes that you'll need. And you can sort of plan for the surgery beforehand. And it's very helpful for knees that have a lot of deformity or have had previous surgery, and it's especially for hips that have had previous surgery or that have some type of deformity, developmental or congenital deformity that you're trying to correct. It makes it a lot easier to plan for the surgery. And then it's a robotic arm. It's not a robot, autonomous robot that walks around the room. Yeah. It's just an arm that you attach either the saw or the reamer or the burr to the robotic arm, and it knows exactly where it is in space based on a predetermined registration and the CT scan. And then you can make the cuts or the burrs or the reams exactly as you plan them. And so that's how it works.
That's really neat. Well, first off, all right, you do the CT scan,
Right.
and how precise can you? Because I know there's different sizes of
Right.
implants. How precise can you get on that before the surgery?
It's almost exact. There's some variation at times in surgery for knees. Almost never change a hip. It's almost always perfect on the hips. But knees, since you have to balance the knee, and so there's some ligamentous things that we can't measure with the CT scan. Mm-hmm. So sometimes we change the knee a little bit, but it's usually right on in the knee too.
That's pretty amazing. And so, all right, so the robot, you said the robot arm knows where it's going to go based on the planning.
Right.
Like, can you explain to me how you plan that out? Is that worked out on the computer?
It's worked out on the computer beforehand.
Okay.
Yeah. Okay. So they send it off to again, somebody in Florida plans it, and then we have a Mako service representative here locally that is in the surgery with us. Okay. And then they usually bring it to us several days before the surgery, and we review them. We look at them and make sure that we agree with the plan. Sometimes we change them. I don't always agree with the way that was done. And so we plan the surgery beforehand. We also know beforehand if we're going to get into something potentially a problem, if there's some bony issues that we need to know about beforehand. So it's always much better to have known that beforehand than at time of surgery. So it allows us to do that. And then at surgery, then we put some checkpoints in and arrays to kind of do some arrays in to mark the bone where it is, and then
This on the scan?
No, we're doing it on the bone.
Okay.
So we register the bone because the bone is already registered in the CT scan.
Okay.
And so then we show the computer where the bone is in real time. Okay. And so then it knows where it is, and then it follows. It has an array in the bone, and then you have an array on the robot, and so it communicates, and it knows exactly where it is in space. And you guide the arm with your hand, and you have to watch for the soft tissue because it doesn't see soft tissue. It's just looking at bone. So you have to watch for the ligaments and everything around it. But then you guide it in, and you're the one that turns it on and off. It's not autonomous yet, although I think that's coming. But it cuts or saws or reams exactly as you plan it.
Are you telling the robot, okay, we're gonna go to this specific spot? Is this all programmed in?
It's all programmed in. So the planning part of it is, it has the CT scan, mm-hmm. and then it superimposes the implants on the scan.
Okay.
And so based on what the implants look like, mm-hmm. then it knows where it has to cut for that implant to fit.
Okay.
And so it shows you the planned cuts. Okay. So you can look at the cuts and say, mm-hmm. that makes sense, or no, I don't like that. That's too big, too small, mm-hmm. and the implant's too big, too small. Because it'll show you the implant on the bone too. Mm-hmm. And so just you want to make sure, confirm that makes sense, that looks right.
Interesting. Yeah, really new to me. And can you? How does using the Mako robotic technology? How does that improve, or how is it different? The outcomes versus, let's say, the more traditional joint replacement.
So I think outcomes are a hard question to answer. Okay, because you have outcomes from objective things like failure and revision mm-hmm. rates. Okay, and then you have outcomes from subjective things like patient-reported outcome study, PROMs, and then you kind of have outcomes from surgeons just based on experience with the thing. Mm-hmm. So, but the outcomes from a revision standpoint, people that don't use the technology will tell you, and it's true, at least thus far, is there doesn't seem to be a big reduction in revisions with it. Okay, so it's not it's not like preventing people from the implant failing.
Okay.
Because the manual technology and even some other navigation systems, they're pretty good, and they have been pretty good. I mean, when you have a 96% success rate, it's hard to get that better.
Yeah.
Given we're dealing with human beings that are a lot of variation there.
Yeah.
So I think that it's really hard to see a difference with that in terms of revisions or failures. What you do see an improvement in is outliers from a standpoint of the way it's cut. We want a certain range of angles on knees particularly.
Okay.
And on position of the acetabular cup on hips. And you see fewer outliers when you use robotics than you do from manual.
So I think what it sounds to me like is more consistent?
More consistency,
Okay, gotcha.
much more reproducibility and consistency. The x-rays look better.
Okay.
And again, and there are some more recent evidence that the patient-reported outcomes are better early on with robotics in the first 6 weeks.
Okay.
After surgery.
Sound like maybe it's a little faster recovery? Would that be?
Apparently, a little less pain, a little faster recovery. Yeah. So, again, not dramatically different because it wasn't bad before, but somewhat better.
Okay.
So I think those are the things. Is accuracy's better, reproducibility's better, and then probably the early patient-reported outcomes are a little better.
Okay. And obviously, you see patients with knees and hips with various situations. And what type patient would most benefit from the Mako?
Well, again, as I said before, I think the ones that have deformity. Again, if their ligaments are pretty normal and they have fairly normal anatomy, and they just have a generalized wear and tear on the knee, I think the mechanical joint works pretty well. I mean, because you're not. But when you have to do a lot of changes and modifications, then the Mako is very, very nice for that. It's especially nice on the hip, on the socket side, on the acetabular side, because you can plan how far you ream, and you get exactly where you want to be. Because some people have very thin sockets, and you when you're doing it manually, you don't know. Frequently, if you're not careful, you'll ream a little too far into the acetabulum, into the socket.
Okay.
This prevents you from doing that. So if they have a shallow acetabulum, you're not going to ream too far. It won't allow you to do that. So as a stop. So I think for those people that have deformities, people with leg length inequalities, for hips particularly, you can use navigation on the robot to measure their leg lengths, so that you have a good idea at surgery exactly where you end up with leg lengths, and that's nice to know, because it's what the most common complaint used to be frequent after hip replacement surgery is that my lengths aren't exactly the same.
Okay.
And so that this sort of prevents that. So that's very handy for that.
And how do you approach a patient to decide between somebody who comes with I don't know if it makes a difference if it's a knee or hip, but somebody who help them decide between a conservative treatment or surgery for joint issues?
So great question. I think that you have to look at the whole patient again. You have to how old are they? What's their activity level? And then you have to get their history on what's been done. What have you tried? Have you had anti-inflammatories? Have you tried to lose weight? Have you had therapy? Have you had injections? Have you tried, if it's a knee, have you tried a brace? I mean, all those things would play a role. And then what are your expectations? I think that's the most important question to ask. What are your expectations? What do you expect to do after getting this, if you do this? Because some patients will have very unrealistic expectations about what they want to do after doing this, especially if they have multiple joints involved. If it's an isolated joint and they're otherwise very healthy and pretty active, then they really don't usually have a lot of limitations. But some people want to think that once they get their joint replaced, they're suddenly going to be 20 again, and you just have to kind of rein them in a little bit and say, no, that's not the way it works.
Yeah.
I can't walk up my stairs and I can't get out of a chair. That doesn't have anything to do with your knees bad. It's because you're out of shape and your quad is weak. It's not so you have to go through all of those things too. So I want to make sure that they've tried conservative things first, if that's reasonable, and that they have reasonable expectations of what the outcome is going to be and understand the risks.
Okay. And how do you guide your patients through the emotional side of joint replacement?
So, I think I try to kind of stay in the middle of what to expect. I think sometimes you can be too encouraging. This is going to be the best thing you've ever done in your life, kind of thing. And I know that works for some people, but not for everybody. So you have to kind of meet them where they are. Some patients, again, have unreasonable expectations, and I try to tamp those down a little bit. Some people have irrational fears. And so I have to kind of bring those people along a little bit. There's some people that just won't, Uncle Joe had one and he got infected and lost his leg. And, I'm never going to have it. Well, I mean, I don't know anything about Uncle Joe, but that's probably not going to be your experience. If you can't walk very far because your knee's bad, I think you would benefit from having the joint replaced, and don't be so fearful of that. But you have to meet them where they are. Again, we don't know people's histories or as to why they think the way that they do, but generally it's based on their life experiences or somebody they know. So I try to do that for emotional. You also have to talk to them about support. It's so important to have support during this time. It's sad the number of people that don't. When you say, well, who are you going to have to help you? And they say, I don't have anybody. That to me is sad.
Yeah.
But it also presents a problem. Those people don't do as well. They're more at risk for complications because they don't have a support system. So you kind of have to just, again, try to learn the patient and try to help them along.
Man, it'd be nice if in those situations, gosh, obviously if they could afford it, even hiring a sitter or somebody to help or a therapist.
That happens sometimes, yeah.
Yeah.
Although I don't want to be too general here, but my experience with sitters is, they're hard to find good ones.
Yeah.
They're just hard to find.
It's too bad. I know a lot of people are moving into value-based care. If there's even a team to help folks that don't have the support system.
Right.
But anyway, and switching topics a little bit, I know it sounds like you got a pretty large workers' comp practice.
Yes, sir.
And can you tell us a little bit about that?
So, I could go back a little bit. So when I joined Alabama Sports Medicine back in the day, I had to find a niche for my practice. We had a lot of guys doing specialty things. They had sports medicine covered. We had a couple of spine guys, had joints covered, hand, foot, and ankle. All that was kind of covered. So I had to find a niche somewhere. And the one thing that nobody really wanted to do there was workman's comp. There's a reason for that, because it can be problematic. It's a lot of paperwork, and some can be a headache. And none of the guys wanted to do it. So I started doing it at that point. Spent a lot of time working at that. Did a lot of talks and went to the various conferences. And then so I built up a pretty good practice. And I was on the medical services board for the state for 10 years and was chairman of that for most of that time, which controls workman's comp laws and rates in the state. So that I did that. So, I just got involved with it, got to know a lot of people in the community, in the work comp community, and so I've stayed with it. Even though I've gotten busier with my joint practice and doing other stuff, I still do it, and I still enjoy it, because once you understand the system, it's not so frustrating. It's different than taking care of the other average patient, because if you have an average patient, what you're interested in is what's the problem and how can I fix it. With workman's comp, it's not only what the problem is, how did it happen? Is it work related? Is, how can I get him back to work? And how long is it going to take to get him back to work? And what's the impairment going to be? And so there's a lot of other questions that you have to answer that you don't really have to answer with the average patient.
What's the common, or maybe not common, what kind of injuries are you seeing with workers' comp?
So I see mostly shoulders and knees. I mean, a lot of shoulder overhead stuff. And then over the years, I've done a lot of carpal tunnel surgeries and a few cubital tunnel surgeries in the elbow, trigger fingers and things like that. They're pretty common in workman's comp. And then you see some injuries, like I had one today. I had some broken arm. He fell off a forklift. It's a broken arm. So, you see some injuries that are different.
What do you do for carpal tunnel? I guess would be in the wrist?
It's in the wrist, yeah. Okay. So usually it's surgery if it doesn't respond to conservative treatment.
Okay. Well, is there anything you would recommend for surgeons, or what surgeons need to be successful serving workers' comp patients?
So I think that you have to be willing to learn how to handle the injured worker. First thing is you have to spend a little time getting to know the employers and the adjusters and the case managers. So there's a lot of people involved in taking care of these folks. But the most important thing is the employer. If it's a bigger company, you need to learn what their expectations are for getting the employee back to work. And you need to learn that your job is to write modifications or restrictions on what they can and can't do, and then allow the employer to decide whether or not they can work, rather than, in general, you don't just take people off work. Let the employer decide that. But the big thing for workman's comp is communication and documentation. You have to communicate with the adjusters and the case managers and the employer about what's going on, and keep it updated. And then you have to document everything, because it's not infrequent that these end up being litigated, and then you have depositions and all. And so you better make sure that you have all your ducks in a row, because you're going to have to review the records.
So it's definitely more paperwork.
More paperwork, yes.
Yeah. Have you ever got, just in your experience, just kind of a ballpark guesstimate of what percentage don't end up going back to work?
So it's not common for the most part. Now, obviously, when it's a severe injury, obviously you have some catastrophic injuries that they don't go back to work. Most of those get taken to the trauma center. I sometimes see them post-injury where they have some reconstructive things, but I don't see most of those acutely, because they usually go to a trauma center. So they statistically, you can read different things, but if you do overhead work and you have a shoulder surgery, they say 60% of those go back to work. So 40 don't. That's a big number. It's a big number. So I think my numbers are higher than that, but I've never looked at it honestly.
There's so many variables too, like age would be a huge variable.
Age is a huge variable. Yeah.
A guy at 30 gets a shoulder problem, it's not going to be the same as a guy 60.
It is not.
Yeah.
No, it's not. The length of time is different. And unfortunately, more and more companies are going to these algorithms where they're called ODG guidelines that they follow. And so they will say, well, the ODG guidelines says you only need 4 weeks of physical therapy for this. But for what age patient, for what problem? It's not every rotator cuff is the same. It's like, and I get a little frustrated with that kind of thing.
And two patients even the same age could have a different time frame, not only because, as you mentioned, differences in the rotator cuff, but people heal differently.
Absolutely. Absolutely. So yeah, I think that's an issue that frustrates people taking care of workman's comp is the second guessing, the peer reviews, and that kind of stuff that you get.
That makes sense. Well, you've been in orthopedics a long time. So you've been with Andrews for 30 years, but you were an orthopedic surgeon in the Air Force before that.
For 4.5.
So you've seen an awful lot. And kind of based on that, what excites you? Are you seeing that maybe coming down the road in the future of orthopedics?
So I think, orthopedics is a very technology-driven specialty. I mean, so I think it'll continue to be that. I mean, implants will continue to change some, although they're so good now. I mean, I don't foresee dramatic changes. I think, they've been working on trying to get something on implants that would decrease the risk of infection, some kind of covering or so. And I think that'd be good because that's devastating for patients is to get a joint infection after getting an implant.
Would it then have to be taken back out?
Usually.
Oh boy.
Usually. So that's just a lot of. They've shown that if you have an infected joint, your risk of dying in the next few years is almost as bad as a cancer diagnosis.
Oh man, I didn't know that.
So yeah, it's a severe. Plus, it's a huge expense to the whole medical system. It's tens of thousands of dollars for everyone. So I think that's something. I think AI is going to ultimately play a role in all of medicine. Helping us diagnose and create templates for us to do stuff that is going to be, I think, good ultimately. I think it's going to be fits and starts to start with. I think virtual reality kind of stuff, we already see some of that. We're designing a new building and we're walking through VR, the new building. And there are some VR surgeries that are being done now.
Okay. And so like with the robot, so you're using virtual reality?
But you can see real time. I mean, you can practice surgery in VR. So that you can kind of practice your skills. So I think that'll be good. You never know. I mean, I think it's hard to predict what's going to happen in the future.
Yeah. But I think you're right when you mention AI. We know is going to play a big role, and that's really interesting about virtual reality, especially for practicing.
Right.
Yeah, that's neat. That's neat. Well, let me ask you this: looking back over your life, what are some of the things you're most proud of? Surviving. Yeah.
I think it's number one. But I think that learning. I'm proud of learning through my life. I was a pretty confident, hard-headed younger person, and I've become more humble over time. Realizing, and I've often heard it said that the more you know, the more you realize you don't know.
Yeah.
And I believe that to be true for sure. So that's humbling. And I think that the ability to continue to learn and to be curious about people and about life is, I'm proud that I'm still doing that at this age and glad to be doing that. I think that, just the life experiences. I was proud to have served the country. I was proud to be in the Air Force and had a mostly good experience there. I did have there was a tragedy when I was in the Air Force where it was a gunman came into a hospital and shot up 22 people. Wow. So that was horrible.
Yeah.
It's 31 years ago today. Actually.
Oh, today.
June 20th.
How ironic.
Yeah. So I had experienced that. I'm proud of my wife. I mean, I couldn't be luckier to be married to her. She's a fantastic woman. Proud of my family. Experienced my son is just graduated medical school and he's starting his residency. So I'm real excited about his future. And my other kids too. The just as far as medicine goes, just who I practice with and what I've been able to accomplish. I'm really proud of that, being part of that practice, helping it grow, continuing to watch it grow, and I'm excited about that. Proud of the people I've mentored. I've taught students for years and years now, mostly PA students, and I'm proud to have done that. The next generation of people coming up, I've mentored kids that have gone on to go to medical school, and there's one now that I've been mentoring for a while that is now in his orthopedic residency, and he thanks me all the time for being such a mentor to him. That means a lot. I'm just proud of that. So I mean, I'm very grateful for my relationship with Jesus and the follow just that part of my life. I'm proud of that. So I think that I don't know. I'm just glad to still be here and still be able to be contributing.
Well, it sounds like you've had a pretty full life.
I have. I've been very, very fortunate. Yeah, in many ways. I mean, I think you could always. I mean, most of us could look through our life and say, "This is not ideal." It's not ideal that my dad died when I was young. That kind of stuff. But overall, I mean, I just to be grateful for what I have and what I've been able to do and things I've got to see and people I've got to meet and relationships I've formed. And I think that for me is especially through COVID, knowing how much relationships matter. I mean, I learned that a lot, and I'm very grateful for that.
Well, again, I want to thank you for coming in, and
Sure.
not only, especially, you're learning about your experience with COVID, and that was really interesting for me, and also what we've talked about today with implants. So, and we really appreciate it.
Absolutely,
And
my pleasure.
Yeah.
Thanks, Steve.
Thanks again. Yeah,
Thank you.
definitely did. Yeah. Thank you for listening to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kasufin Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.